Greetings, Manoel GalvaoNeto, and it's a pleasure, honor, and a joy to be among you today. Unfortunately, I couldn't be in present, but you are receiving this recorded presentation that I'm doing specifically for the meeting here from Orlando, Florida, from Orlando Health Weight Loss and Bariatric Surgery Institute. But as in India, I work closely with Dr. Mohit Bhandari, Dr. David Cummings, and the team of Mahak Bariatric Center in India. So let me share my presentation with you. And you see here the team that we proudly work with. And getting to the point, it is that we are debating on this workshop, this the weight gain after menopause, and why this happens, and how the tools that you have to address that. So really, possibly, you already have saw that. So it's a different perspective on that. Menopause, basically, it changed the rules. So what worked before in terms of weight control and weight loss simply stopped working. So because loads of things, estrogens drop, metabolism is low, hunger signaling really shifts, muscle mass, because of all of these, we will get into some decline. And the lifestyle of efforts often plateau, demanding even more effort to control the weight. And we know that's not just the weight, it's that comorbidities that it brings together with the weight gain after menopause. And it's not a lack of discipline, it is just pure biology. So it's hard to face that. So in our toolbox, you see that you have the obesity control by medicines, the surgery, and I will talk to you the possibility of controlling or to help you control it by mouth without surgery, but with interventions. So let me start talking about the intragastric balloon that we are doing now more than 25 years. It is something that we put by the mouth with the aid of endoscopy or not. So we inflate this balloon, generally with a liquid, and it stays there in between 4 to 6 or 1 year. And it really helps control. As you can see, it occupies space in the stomach. So the food that feeds before not going to feed after that. And it's very well studied. We cover all the evidence, but now there is some sort of overlap with the GLP-1 analogs they are really, really efficient. So there is some struggles in the indication or not. But in India, with the team, specifically by the ideas and leadership of Dr. Mohit Bhandari, we went further. That our previous studies, like this one, that's a case match study that we put the intragastric balloon with liraglutide. And we know one of Achilles tendons of the balloons is when you remove, they are very effective in inducing weight. But when you remove, the patients regain weight short after. So in this study that we published in a very important journal, so we have those patients and we case match them in a retrospective way in patients that after balloon removal, we just gonna be followed, or they're gonna be applied doses of liraglutide, that one of the oldest GLP-1 analog. And you can see here on the graphs that if we use liraglutide, the patients keep the weight they lose for more time. So it was the initial thought on that. And in India, in Mahak Center in India, we did even more. So the new swallowable balloon, that is just a capsule that you swallow, and then we blow that with a liquid in your stomach, and then there's no need for endoscopy to put it in, take it out. And we are among the pioneers with thousands of cases done. And just yesterday, we got the news that this balloon is now FDA approved. It was approved outside the United States, but now it's approved here in the United States. So we're going to start using here. So what we did, we used with a more modern GLP-1 analog that in the oral form, and we could able to extend and improve the weight loss for the balloon. For example, in the lower line, you're going to see the balloon alone. In the upper line, you're going to see the balloon plus the GLP-1 analog in this oral form that not even that powerful. But you can see here delta, a difference of more than around 5% of total body weight loss. So this is statistically significant, and it helps us to get the trend, and we are very used to do that clinically now in our center in India, and we start here in US. And the other is the gastric remodeling. You see here that the stomach is kind of plicating, and we do that by endoscopy, and it's a huge success. In a way that we cover all the literature up to the level 1 evidence. We got FDA approved. We now, since this January of this current year, we have a CPT code, meaning that we start going to be reimbursed here in US, and in India is already being reimbursed on our center. And then comes that is in the clinical use, and for what patients? So lower BMI patients, and you can see here that we go to every single barrier. In the last one, we just got over with our new publication that get here published in January of this year, that our team in India shows the largest number of patients in the long-term follow-up. So more than 1,000 patients, exactly 1,377 patients, followed for 6 years. And you can see here that one very important thing, this graph, is the follow-up, because most of the long-term studies, they don't have that good follow-up as we have in India. 60% of those patients, almost 400 patients were followed for 6 years. And what happens is that you see this graph of weight loss, they really lose weight and they keep the weight that they lose. And you can see here as a peak of 20% total body weight loss, but in 6 years it's natural. Any procedure, any treatment, patient's gonna adapt, gonna regain a little bit of the weight, but you can see here it's not that much at the end of 6 years with a good follow-up. In this perspective, 14.4%. And we now are proving that we can even extend more our reach in terms of weight loss. In a version 2.0 that was pioneered also in our center in India, it is a matter of adding the GLP-1 analogs. Doesn't have to be the most powerful, it can be just small doses on that, with the tool, offering the tool and the metabolic control GLP-1 analog. So we have very important publications, like one of the case match study, that we put even an oldest GLP-1 analog, that's liraglutide. You can see here we match 26 patients in each group. And you can see here on the right side of the screen that the patients that just have the ESG, it was in Brazil, but you see the similar result that we have in India at 1 year, around 20%. But when we add the GLP-1 analog, we go to almost 25%. And with the new GLP-1 analog, we predict that's going to be even more. So we're getting now surgical results on the entrance level, like the sleeve gastrectomy on that direction. And this was corroborated and reproduced by the studies, important universities here in the US, like Harvard, as you can see here. And if you go and see the very initial column on more dark blue on the left, the combo therapy of the endoscopic gastric remodeling, the DSG, plus GLP-1, it got around 25% total body weight loss. So matching what we have done here, so this is reproducible. So we are putting on another level of that, and we are practicing that on a daily basis with huge success in our center in India. Also, we have what we call the ESG plus. This plus meaning adding a bowel component like bariatric surgery has. So, for example, we do endoscopic gastroplasty and we do an anastomosis. We put the bowel or jejunum or ileum together with the stomach. We enhance even more the results. So what you see here, and sorry for the picture, is a fresh endoscopic sleeve gastroplasty. You see the stomach is remodeling, and at the end, we add a loop of the bowel, but it's better see here on the laparoscopic image. You see how we really, it's like a woman trench. We can model the stomach, and this is the bowel attached to that. Important to know that we already follow those patients for 2 years, and we compare with this procedure that is pure laparoscopic, that sleeve gastrectomy plus the bowel partition, with the endoscopic procedure plus laparoscopic with very few incisions. And you can see here the results are the same, and they are very good, over 30% total body weight loss. And even more, our centers is advancing in pioneer as first in human studies, the magnetic anastomosis that's going to be even less invasive. That you can see here, Dr. Mohit Bhandari, he is just implanting on the bowel, in this case it's the ileum, implanting a magnet. So this proceeds by this small device called autolock, and now we are open the magnets in this cannula. It opens like an octagon. So, and when he finished, we by endoscopy, by the mouth, we're gonna go inside, and through the scope, we're gonna pass this magnet, and you're gonna have the opportunity to see how this technology works, because you're gonna see that the magnet on the upper right quadrant of the screen, and now the magnet is being attached to the scope, and you're gonna see the upper right quadrant that the magnet gonna be passed to the channel, and it auto forms in an octagon way. Just in the middle, just getting out on the upper right. So once it's formed, we bring them to this cap in the front of the scope. And then what we do suction, and we become, and you're gonna see in a minute, we become a target to Dr. Mohit Bhandari. And what he has implanted on the bowel, you're gonna see here this fantastic image that he's gonna attach the stomach with the small bowel with no suture, no staple. And this will form in 7 to 14 days, and the magnet will pass through the bowel, no foreign material is there. I'm gonna show you just after how it is. So you can see it's a fresh sleeve gastroplasty and the magnet there. And by the end, you're gonna see here, by the, sorry, let me go further. By the end of 1 month, you're gonna see here that the anastomosis is already formed, and we got in the both sides with this loop anastomosis on the direction. And we can do that with the stomach, and even more, we can do that with the duodenum. Again, you see here on the left upper quadrant that we are staining the magnets, and then we're gonna look for the light of the laparoscopic. We apply suction, and again, Dr. Mohit Bhandari, with those special graspers made of titanium, not to get attached to the magnet, we just cover this, and it's done. It's a 5-10 minutes procedure, plus the endoscopy on that direction. And you can see inferior right quadrant, you're gonna see here, 3 months after, the beautiful anastomosis formed on that direction. So with that, we can reach surgical results on that direction. So we are evolving as a technique, and we predict that in 2 years, we can do that fully by endoscopy that direction. And even more, we have what we call metabolic endoscopy. That's the duodenal mucosal resurfacing. This is very specific for overweight and obese subjects or patients that they have diabetes. And we discovered in our research that diabetic patients has a problem on the bowel, in the proximal bowel duodenum, that we call the diabetic duodenopathy, that wasn't never thought before. As you can see here, the image on the upper part with the lower part, upper part's normal, lower part is diabetic. There's a disarray of the mucosa. It impacts on the metabolic, because this duodenal mucosa is related when it's a diabetic dysfunctional one, is related with quite some of our metabolic impairments that we have associated to that. And the idea is with just ablate this mucosa, a new mucosa will arise as without a less diabetic or non-diabetic drive on that direction. And the way to do that is that we use different technology to ablate, and like as a golden rush, because endoscopy can do by thermal. When you have this balloon and we go to the mucosa, we lift the mucosa, thermically isolating the mucosa for the other layers of the duodenum, and we apply heat on that direction, so we denaturate the mucosa. You can see here we are running now an FDA trial here in our center in US. We can do what I really like as technology right now, electric. You see this disc, and mainly what you do is that you, over a wire, you dislodge this catheter. After the papilla, you open this disc, and you apply electrical pulse, and the cell's gonna die per apoptose. They're gonna be replaced in that direction. And again, we are finishing here an FDA trial. We are one of the centers part of here. And also, there is a steam that this very interesting device is through the scope. It's not a catheter base. It's a catheter base, but through the scope, not over the scope. And you can see here that how they apply this steam. So they open like 2 discs. Now it's a balloon, but this is the first generation. And you're gonna see here in moments that you're gonna see steam vapor coming out of these. And you can see here just after how it is, and this is gonna be completely recovered in 1 or 2 months. And more important, we just get this paper on a very important journal showing us that 2 years results with the electrical pulse. And you see here the first 2 curves, they were first generations, 1 ablation, and we go with the light green curve, you go up to 8 weeks, almost 2 years. You're gonna see that the drop of H1C, glucose, and weight, they are very, very interesting. So we are waiting here. We're gonna finish the FDA trial by March or April. So we're gonna have more on that, so that we can modify the disease itself. So at the end, it's a matter of trying to treat biology with biology. And how we position that in the bariatrics, we get a durable gastric remodeling inducing weight loss. If we add GLP-1 analog in the base pharmacotherapy, even microdosing, so we impact in the central appetite regulation, targeting visceral fat dominance, improving cardiometabolic risk, and bridge between lifestyle therapy and surgery, and also the medicines. Our core message is that the combination therapy, we can deliver precision care for menopausal obesity. So thank you very much for watching.